Another example was a patient I was asked to see after an operation on his chest. It collapsed and there was this minor complication which I was able to help the surgeons sort out. And when he came round from his illness, recovered from his operation and the complications, turned out that the operation had been to remove something in his lung which happened to be pneumoconiosis rather than cancer, as they'd thought. Pneumoconiosis is a dust disease of coal miners. So I asked him what coal mine he worked in, and he said he didn't work in a coal mine, he worked in a shale mine. At the time, it was not known that shale mining, which was extinct actually, the industry had closed about 20 years before, but it wasn't known that it caused pneumoconiosis. So I burrowed around and found some more cases of pneumoconiosis in shale miners, and this was the time of the oil crisis in the 80s when the Arabs had put the price of oil up and the Americans got very panicky and started exploiting shale in the Rocky Mountains. They wanted information on the hazards of shale mining, and I was able to get a grant from the US Department of Energy to study the effects of the shale mining on people in and around Edinburgh, which had been the centre of the shale mining industry from the 1850s up to the 1950s. So that was another example of a link between a patient and a research grant. So I've always been a believer in having someone in medical science who's actually in contact with patients.